My name is Max Westlake, and I will be talking about the interactions of neuromuscular blocking agents in patients with myasthenia gravis. I'll start by briefly reviewing the mechanism of myasthenia gravis. It's mediated by autoantibodies that attack postsynaptic acetylcholine receptors, and therefore do not allow that receptor to create a depolarization needed for muscle activation. This essentially results in less functional receptors. And this concept is important to understand as it affects the action of neuromuscular blocking agents we use in anesthesia. Moving on to our depolarizing blocker, succinylcholine. It acts as an agonist at the postsynaptic acetylcholine receptor, and therefore it relies on generating an initial depolarization. Once this depolarization occurs, it's unable to be broken down by the acetylcholinesterases, and it keeps the receptor in this inactivated bound state. Next are the non-depolarizing agents like rocuronium, and they're simply competitive antagonists, as they will outcompete acetylcholine at the receptor, and therefore no depolarization can occur. So what happens to these agents in patients with myasthenia gravis? These patients are less sensitive to succinylcholine and need a higher dose. As I stated earlier, these patients have fewer functional postsynaptic receptors. Succinylcholine relies on functioning receptors to create a depolarization. Therefore, more agent is needed to cause this effect. In contrast, these patients are more sensitive to non-depolarizing agents like rocuronium and need lower doses, because these agents have fewer functioning receptors that they need to block. These concepts are important in clinical anesthesia for patient safety. Adequate dosing is needed, as underdosing can lead to difficult intubation, and overdosing can lead to prolonged paralysis and weakness. With succinylcholine, studies have shown double the typical dose is needed for effect. However, with this increased dose comes the risk of a phase 2 block. When using rocuronium in these patients, a reversal agent should be used, and its effect should be confirmed with train of 4 before extubation, as they're at higher risk for reintubation post-op. That concludes my talk. Thank you for listening.